Welcome to the Deep Dive. We're your shortcut to understanding complex research.
Glad to be here.
Today we're tackling metastatic colorectal cancer, mCRC for short. It affects so many people.
It really does. A huge challenge.
And our mission, well, it's to unpack a recent study looking at a new triple therapy. We want to show you how it's working, especially against those tricky liver metastases.
Right. mCRC is tough. And while we have treatments, we always need better ones, especially for the microsatellite stable type, MSS-mCRC. Immunotherapy hasn't had much luck there traditionally.
Exactly. So the focus is this phase 2 study. It came out in JCO Oncology Advances just this February. It's looking at combining 3 drugs for a specific group of mCRC patients. And honestly, there are some surprising facts in here.
Definitely some intriguing results.
Okay, let's get into it. First off, microsatellite stable metastatic colorectal cancer. What does that actually mean for our listeners?
Well, basically, it's the most common type of colorectal cancer. But the issue is, historically, immune therapies, things like Nivolumab, pembrolizumab, those checkpoint inhibitors,
They just haven't worked very well when used on their own in these MSS patients. Very limited success.
Right. And why is that such a roadblock?
It's complicated, but essentially the immune system isn't easily seeing or attacking these specific tumors. Now, in other cancers, adding a second type of immune drug, a CTLA-4 blocker like Ipilimumab, help boost the response.
Okay.
But even that combination hasn't been a home run in MSS colorectal cancer, still quite limited. So researchers have been, casting a wider net, looking for other ways to make immunotherapy work for more patients.
So you've got this big group of patients, MSS, mCRC, where standard immunotherapy isn't great. And even standard targeted therapies like Panitumumab, that's an anti-EGFR drug, right?
Correct. Targets a specific protein called EGFR.
It's approved for certain cases, patients without KRAS, NRAS, or BRAF mutations, and usually left-sided tumors. But even then, used alone, the results are, well, modest.
That's fair to say. Looking back at the data, you see maybe a 22% response rate. And patients typically progress after about 4 months. 4 months! That's not very long. So clearly, we need something better, something more effective.
Absolutely. And that leads us to the really clever idea behind this study.
Okay, lay it on us. What's the hypothesis?
So researchers noticed something interesting. In those colorectal cancers that did respond to drugs like Panitumumab, the EGFR blockers, they saw more immune cells, more T cells getting into the tumor. And crucially, the tumor started expressing more PD-L1 and CTLA-4. Those are the don't eat me signals that immune therapies target.
Okay, so the EGFR drug itself might be making the tumor more visible or vulnerable to the immune system, like it's priming the pump.
Exactly. That's the core idea. It's like the Panitumumab sets the stage, making the tumor environment potentially more receptive to those immune checkpoint inhibitors.
So the researchers thought, okay, let's combine them. Let's hit it with Panitumumab and Nivolumab, the anti-PD-1 drug, and Ipilimumab, the anti-CTLA-4 drug.
Precisely. They hypothesized that this triple combo would significantly boost the response rate, specifically looking at how many patients responded by the 12-week mark.
Okay, clever hypothesis. So how did they actually test this? What did the trial look like?
It was designed as a phase 2 trial, multi-center, meaning several hospitals participated, but single arm.
Single arm, meaning no placebo group, just everyone gets the treatment.
Correct. No direct comparison group within this specific study. They enrolled 56 patients. This was between March 2018 and June 2020.
And who are these patients?
They all had metastatic colorectal cancer that couldn't be surgically removed. Importantly, their tumors were KRAS, NRAS, and BRAF wild type, meaning no mutations in those key genes, and confirmed as microsatellite stable MSS.
Okay.
And crucially, they had already had chemo, at least one previous line of therapy. About half had one line, half had two. But, and this is key, they had not previously received any anti-EGFR drugs like Panitumumab or any immune checkpoint inhibitors.
Got it. So a specific group. And what was the treatment plan? How did they give these 3 drugs?
So Panitumumab was given intravenously, 6 milligrams per kilogram once every 2 weeks. Nivolumab was also IV, 240 milligrams, also once every 2 weeks. And then Ipilimumab, the CTLA-4 inhibitor, was 1 milligram per kilogram of secdave, but only once every 6 weeks. So it's a slightly different schedule for that one.
And patients stayed on this regimen
until the cancer progressed, or they had side effects that were too severe, or, they decided to stop the trial.
Right. And the main thing they were measuring.
The primary goal, the main outcome, was the overall response rate, basically, the percentage of patients whose tumors shrank significantly measured at 12 weeks. They used something called a Simon's two-stage design.
What does that mean, simply?
It's a way to run trials efficiently. They set a benchmark beforehand. They needed at least 18 patients out of the 56, so 32%, to have a response at 12 weeks to say, okay, this looks promising, it's worth studying more. They compared this against a baseline assumption of maybe 22% response, hoping to see something closer to 35% or more.
Okay, makes sense. So the big question, what did they find? Did this triple combo deliver?
Yes, it did. That's the exciting part. The study met its primary endpoint. Out of those 56 patients, 18 responded by the 12-week mark. That's a response rate of 32.1%.
32.1%. So it crossed that threshold they set.
It did. It clearly exceeded that predefined bar of 17 responses needed to declare it worthy of further study.
That's great news. What else did they find when they looked deeper? Any other key numbers jump out?
Yeah, a few things. If you look at the best response achieved at any point during the treatment, it was actually a bit higher, 36%.
Okay.
The median progression-free survival, how long patients lived before their cancer worsened, was 6.8 months.
6 months. How does that compare to the historical data for just Panitumumab?
Well, remember, that was about 4.1 months, so 6.0 months is definitely an improvement.
Yeah, nearly 2 extra months on average.
Exactly. And the median overall survival, how long patients lived in total, was 17.4 months.
17 months. That sounds pretty significant, too.
It is, and maybe even more compelling. They followed these patients for quite a while, a median of over 43 months. And even after all that time, 4 patients, which is about 7%, were still alive without their cancer progressing.
Wow. Long-term responders.
Yes. And interestingly, 2 of those 4 patients initially had liver metastases. That suggests a really durable response is possible for some people, even with liver involvement.
That's really hopeful. Okay, but what about the flip side? Safety. Combining 3 drugs sounds like it could have more side effects. How did that look?
It's always a concern, you're right. Overall, the combination was considered generally well tolerated, but there were, of course, side effects.
What were the common serious ones, like grade 3 or 4?
The most frequent grade 3 or 4 issues were things like increased lipase, that's a pancreatic enzyme in about 9% of patients, increased amylase, another pancreatic enzyme in 7%, some liver enzyme elevations, ALT or AST in 5%, diarrhea in 5%, low phosphate levels in 5%, and a specific type of skin rash, maculopapular rash, also in 5%.
Okay, so manageable for most, it sounds like, but definitely things doctors need to watch for. Were there any really serious events?
There was one very serious event, unfortunately. One patient experienced grade 5 myocarditis, which is inflammation of the heart muscle, and sadly, it was fatal.
Oh, no.
Yeah. It's important to note, though, that this specific risk, myocarditis, is actually listed in the prescribing information for the Nivolumab plus Ipilimumab combination already. So it's a known, albeit rare, potential side effect of dual checkpoint blockade.
Understood. So a known risk, but still tragic for that patient.
Absolutely. There was also one patient who had a colonic perforation, but that was considered related to the underlying disease, not the treatment itself. But taking it all together, the researchers felt the overall safety profile was acceptable for this combination.
Okay. Now, you mentioned something earlier that sounded really significant, the results in patients with liver metastases. Let's dig into that because that often seems like a really tough scenario.
Yes, this was perhaps one of the most striking findings and really interesting for anyone following this space.
Why is that?
Because, as you said, MSS colorectal cancer that has spread to the liver is notoriously difficult to treat with immunotherapy. Response rates have typically been very, very low, dismal even. But in this study, the response rate among the patients who had liver metastases was 32%.
32%. Wait, how does that compare to the patients without liver mets in the same study?
That's the kicker. It was almost identical. The patients without liver mets had a 33% response rate. So basically, the presence of liver mets didn't seem to negatively impact the response to this triple therapy.
Wow. That seems to fly in the face of previous experience. How does that compare to other recent trials you mentioned?
There's a stark contrast. For example, there was another recent study looking at a different immunotherapy combination, botensilimab plus balstilimab, called BOTBAL. In their trial with refractory MSS CRC patients, they had 24 patients with liver metastases. 0 responses.
No.
0. Okay.
And another one, the RAN study, combining regorafenib with Ipilimumab and Nivolumab, they had 7 patients with liver mets. Again, 0 responses.
So 32% versus 0 in similar patient groups. That's a huge difference. What could explain that? Why did this combo seem to work in the liver when others didn't? That is the million-dollar question, isn't it? And we need to be careful here. The study authors themselves point this out. Remember, the patients in this trial hadn't had prior anti-EGFR therapy.
Right. They were EGFR inhibitor naive.
Exactly. And they'd only had 1 or 2 prior lines of chemo. Plus, Panitumumab, the anti-EGFR part of this combo, is known to have some activity on its own in these patients.
Ah, okay. So the caveat is we can't be absolutely sure if the good results in the liver mets patients were purely because of the panitumumab doing its job, or if it was truly the combination, the synergy between the EGFR blockade and the dual immunotherapy that made the difference.
Precisely. It's a very promising signal, especially given the historical failures. But this study design, being single-arm and using an active drug like panitumumab, doesn't let us definitively tease apart those contributions. We can't say for sure it was an enhanced immune effect.
Makes sense. Important context to keep in mind. So, like any study, it's not perfect. What were the main limitations the researchers acknowledged?
Well, the big ones we've touched on. First, it was a relatively small study. 56 patients isn't huge. And second, it was single-arm. No internal control group getting, say, just panitumumab or just the immunotherapy to directly compare against within this trial.
Right. Comparisons are based on historical data, which isn't ideal.
Exactly. Also, they noted limited representation of different races and ethnicities among the patients enrolled, which affects how broadly we can generalize the findings.
Okay. So acknowledging those limitations, what's the bigger picture here? How does this study fit into the evolving landscape of treating metastatic colorectal cancer?
I think it adds a really significant piece to the puzzle. It reinforces this growing idea that dual checkpoint inhibition hitting both PD-1 and CTLA-4 does have real activity in some patients with MSS colorectal cancer, a group previously thought unresponsive.
Even if it's a subgroup.
Right. We've seen other attempts combining PD-1 or PD-L1 blockers with different novel agents that haven't panned out so well. But this approach, using the PD-1 CTLA-4 combo as a backbone and adding something else like the EGFR inhibitor here, seems to show some durable activity for certain patients.
So it strengthens the case for this dual immunotherapy approach in MSS-CRC.
I think so. It definitely suggests this strategy, particularly combined with EGFR blockade in the right patient population, needs more investigation.
And what did the authors conclude? What's their main takeaway message?
Their conclusion was pretty clear. They felt the efficacy results strongly support moving forward. They recommend evaluating this kind of combination immunotherapy plus EGFR blockade in a larger randomized trial.
Randomized meaning with a proper comparison group this time.
Exactly. And they even suggest it might be worth considering testing this combination earlier, maybe even in the first-line setting for newly diagnosed metastatic patients, especially as the whole treatment strategy for mCRC keeps changing.
Interesting. So potential for moving this potent combo earlier in the treatment journey.
Potentially, yes. That would be the next logical step if further studies confirm these benefits.
Okay, let's wrap up this deep dive. The core finding seems to be this new triple therapy, Panitumumab, Nivolumab, Ipilimumab, showing real promise in a tough-to-treat cancer, MSS, mCRC. We saw improved response rates, decent survival times.
And crucially, those durable responses in some patients.
Right. And the really intriguing part for you, the listener, might be its unexpected activity against liver metastases, a major hurdle in the past.
Absolutely. While we need more research to confirm why it worked there, it's a genuinely promising signal. It suggests that maybe combining targeted therapy like EGFR blockers with this dual immune checkpoint approach could open up new avenues for patients who've had pretty limited options until now.
It definitely feels like progress. So here's a final thought to leave you with. We know the location of metastases like the liver can drastically affect treatment success. How might this evolving understanding of combination therapies like the one we discussed today start to reshape strategies not just for colorectal cancer, but maybe for other challenging cancers where the specific tumor environment is a key factor, something to ponder?